when I talked earlier, we talked about incorporating chronic opioid therapy and assessment of who gets put on it. And then Dr. Subera kind of came in and talked a little bit about monitoring and about urine drug screens, things like that. So this is going to overlap a little bit, but again, this is the meat and potatoes of what we have to do to prevent diversion, prevent abuse, and provide good care to our patients. It is ongoing monitoring, it's ongoing testing, and we're going to spend a lot of time talking about the different kinds of things that we do to monitor patients. It's not just urine drug screens and pill counts, it's a variety of things, and oftentimes it has to do with interaction with the patient. So the goals of monitoring, we talked about how we want to incorporate this COT program, this chronic opioid therapy program. Well, we want a safe and we want an effective treatment plan, and we want improvement in the activity. And again, when we monitor patients, we want to discuss with them what we're looking for. I think that patients in a pain management setting, especially what we try and do in our office, is that patients oftentimes, I rarely have somebody bristle up when asked for a urine drug screen. Part of that is the education of the patient that there's a big problem with diversion. They all read about it in the paper. I tell them that our state is typically in the top 5 in the country and that deaths are high. And the ones who have legitimate and ongoing chronic pain, they understand that in order to receive the treatment they get, that we do have to monitor on a regular basis. And discussing with them in a friendly fashion, in a professional fashion, goes a long ways towards getting them to understand and buy into the concept of this pain management program that we're starting. So I think, again, just as we talk about expectations, we also have to talk about the goals of our monitoring with patients before we start. But we're trying to prevent deaths, and we're trying to prevent drug abuse. We'll talk about opioid deaths because they're big. Oklahoma's 3rd in the country. West Virginia's number 1. Utah's number 2. That was from 2011. Methadone deaths contribute to that, but there are certainly across the board prescription opioid deaths causing. What's important is that most deaths are due to non-prescribed opioids. Very rarely, compared to the general group that succumbs to opioid deaths, is the drug prescribed only for that person. The medicine cabinet is our biggest problem, because how many times a day do I hear, and how many times a week do I hear, I had friends over, I had my daughter's boyfriend was over, et cetera, my drugs are gone, they were taken away. Most of that stuff is non-prescribed. Lethal combinations, alcohol and opioids, benzodiazepines and opioids, Seroquel and opioids, sleep medications and opioids. All of these things cause this toxic soup within the brain. It's one of the things I look for when patients start to develop a cognitive fall and they've been on a stable dose of opioids is, like I said in my first lecture, what have you been started on? Is there any other medication that you've been given? And oftentimes, that may be it. That may be just a benzodiazepine given to them for anxiety by their primary care physician. We'll again talk about methadone because methadone deaths are huge. They're actually gone down, I believe. But again, like I said in the first week of treatment or a dose change. Again, people simply start methadone too high and they dose it too often and they dose it too aggressively. I believe in my practice, even if somebody's opioid tolerant with moderate doses of opioids, maybe 4 to 6 hydrocodone per day, 5 milligrams once a day, and they don't get dosed or increased for 7 days. That's very conservative, but I want to be conservative, and I try and educate my patients that you'll call every week, we'll increase the dose if we need to, but the problem arises whenever you start to say, okay, 5 milligrams, 4 a day, and it accumulates, and it accumulates. The half-life is 36, 45 hours. 5 half-lives, 4 to 5 half-lives equal, you know, steady state. So these patients are then succumb. The other thing with methadone is don't give it to patients who have a history of abusing their medication. Don't give them a pill bottle full of methadone. In the sense, don't give them a pill bottle of long-acting opioids if they've got a history of abuse. It's always hard to tease out pseudo-addiction and tease out under-treatment of pain, but it's always best to err on the side of conservative. We know a lot about the cardiac issues and prolonged QT, typically with causing sudden cardiac death. That is typically seen with high-dose opioids or high-dose methadone, but can also be seen with lower doses. EKGs may be indicated periodically. Prescription drug monitoring. When patients come into my office, I ask them the 4 A's, kind of like Dr. Subero was saying. I document those 4 A's. I try and talk about, and it's a very quick. Patient is doing well, analgesic levels are well, the patient's activity of daily living are improved, the patient's able to exercise and go to the gym and has lost weight. There are no aberrant drug behaviors. Last year in drug screen was consistent. OBN website check today showed no inconsistencies, and the patient has no adverse effects. Adverse effects are the sum. Everybody gets constipation. That's there. It's never going to go away. Adverse effects are typically seen within the first week to 2 of opioids, and they're itching and they're nausea, and those typically tend to pass. I don't like to treat side effects of opioids with other medications. I don't use a lot of Provigil. I don't use a lot of Phenergan to treat side effects. I think that comes about by addressing the primary opioid. But the 4 A's are a very useful tool, and it's important to note that, you know, these are some of the same things we talked about when we started opioid therapy, but bullet point number 2 is very important to remember. The risks don't remain static. Patients will fluctuate up and down, and when patients come in and they're having increased pain and they're having their ADLs fall down and they're just not doing well, the first thing I ask them, what's going on in your life? What is up? Because typically they'll say it's depression, it's anxiety, it's financial, it's loss of job. Something has caused them to fall down. I tell my patients, I try to explain to them, we all have a bucket full of stress, a bucket that can hold our stress. And most people's bucket is full, maybe a quarter, and it fluctuates. But when you have chronic pain and your work comp injury perhaps, and you're losing money and your family is not doing well, that stress level goes way up with the pain. And then all of a sudden you throw in just a little bit of depression and it's overflowing, or a little bit of anxiety. And they tend to see it that way, and they tend to understand that as being, hey, that makes sense. The other issue is, have they had a worsening of their condition? That's not as common. It's very common in cancer pain population. That's the number 1 cause of worsening pain, is a worsening of their condition. But in chronic pain, typically not so unless they've re-injured themselves. Chronic opioid monitoring, it's always good as you're going along, even in your patients who are doing really well, to think, can I go down? Can I change? Do we need to continue this same thing? Again, remember, the ratcheting up of opioids with the reducing in ADLs is the most common problem we see. Patients are just simply too sedated, too somnolent, too just, as my fellowship professor said, opioids don't just constipate the gut, they also constipate the brain. And that's the problem you kind of run into, and it's good to just identify these people, and that's why you have to see them on a regular basis, because if you don't, you're going to miss things. You're going to miss things, and you're going to have problems. And I do like the family member in there. I like to ask the family member. I like to ask the patient how they're doing, and then once the patient tells me, I look at the wife or the husband, and I say, is he telling the truth? And they'll laugh, but they'll tell you. They'll tell you otherwise. Risk stratification. Going into chronic opioid therapy, we need to stratify out risk, and we need to look and say low risk, high risk, or ideal patient versus non-ideal patient. And some of the factors are, again, we're kind of going to go over this again, but it bears worth repeating. Chronic pain state, what do they have? How long have they had it? How functional are they? How are they adapting to this disease state that they have? Because chronic pain is truly a disease state. I mean, it affects you. It's multi-organ. It causes significant atrophy and deconditioning of musculature, decreased, cardiac and pulmonary function through just simply lack of any aerobic exercise. You'd be amazed at how many patients of mine, I ask them, other than the bed and other than the recliner, how much time do you spend up? And it's amazing how many are just 18, 20 hours in a bed or a recliner. And then that's depression. And they take a downward spiral. So all of that stuff has to be assessed on a regular basis, and you're looking at improvement in those. Pain is subjective. I don't want to use 180 morphine equivalents a day to make a pain score go down from 8 to 6. I want to use that medication a day to make the patient's functional levels go up, to make their activity levels go up, to make their interactions with their family members and things like that go up. That's what I'm looking for. Older adults, that's a concern because they may have some renal insufficiency. Certain medications, certain opioids don't leave their system well. They're not excreted well. History of occupation requiring mental acuity. Dr. Weineke commented about chronic opioids and how there are good studies that show that patients who are on chronic opioid therapy actually can do better with cognitive function testing than those patients who aren't on chronic opioids but have pain. Yet, on the other hand, I'm not going to let a school bus driver take opioids. I'm not going to let an over-the-road trucker take opioids, and neither is the government either. But there are certainly occupations that preclude. Unstable social environment. Patients who have teenagers, patients who low income. I'm not trying to be prejudiced at all, but the studies will say that patients on Medicaid do tend to have more of an abuse issue than patients who are on disability have more of an abuse issue. And you got to remember, these medications they get a lot of money on the street, and I'm sure it's a very, very lucrative thing that somebody could be swayed into doing. Physician, protect thyself. Again, any abuse pattern, pay attention to it. Don't just turn a blind eye, because if you turn a blind eye, what's going to happen is this problem's going to magnify in the next 4 to 8 months, and you're going to be looking at a situation where we got a real significant problem here, and I've let them lose a couple of scripts, and then their bag got stolen at the airport, or they dropped this one in the toilet. These things happen, and as they start to happen more and more, physicians get in trouble if they don't put a stop to that. So any lost or stolen prescription, I believe, needs a discussion by me, by my clinical staff, and the appropriate thing to address that doesn't occur. So you can only monitor through follow-up and documentation is, again, the key. Documentation gets physicians in trouble. No physical examination, no true etiology for pain. If I'm treating somebody for back pain, typically I know what they've got. I have a large work comp practice, and typically I know they've got previous back surgery or herniated disc from a work injury, and I've got a lot of records. But when you have somebody come in who has chronic headaches or they have chronic low back pain, and they really haven't had any imaging studies, and you're not getting a consultation, and you're not getting imaging, but you're giving them Soma, Xanax, Lortab, Soma, Xanax, Lortab, Soma, Xanax, Lortab, and you're not paying attention to the lost prescriptions and all that. And all of you are probably saying, that's not me, but there's physicians out there who do that, and I see records, and I look over things, and it really does a disservice to us who are trying to do well. So the available tools of the PMP website, use it all the time. Use it all the time. It's such a good tool. And our physicians in this state are among the highest to use that in the country. Urine drug screens, which Dr. Sabera talked at great length about, but pill counts. If they don't have the drug in their system, they need a pill count. My patients are told to bring your pills to your appointment every time you come in. We may not want to look at them, but we want them there Because if you have a negative urine, even on your preliminary test before I send it off to the lab, I want to count the pills. I want to make sure that you're not taking those pills and selling them, and that's why you have a negative urine. Pharmacies. When your pharmacy calls you, please listen to them. The pharmacist can pick up the phone and they can call somebody who really will listen to them, and that probably will not be in your best interest. The pharmacists really help me out a lot. They'll call you and they'll say, hey, did you know so-and-so? Or so-and-so looks very bizarre when he came in to pick up his medications. Or so-and-so's mother really is concerned and she doesn't want to talk to you, but she talked to me and I'm just relaying this to you. Now, there's HIPAA stuff all there, but the bottom line is I'm trying to protect society. So I'm going to try and address those issues. Yeah, do I have patients calling up and going, yeah, you know, my ex-wife that you know what, she's selling her pills. Well, you know, you bring them in and you talk to them, but there's various grades there. Everybody's different in how you handle them, but you have to have a pretty consistent monitoring program. But the bottom line is you're obligated to protect yourself as a physician, your patient, and society. This is the escalation of narcotics and benzodiazepines, and it's amazing. It's almost exponential, and Lord knows where it's going to be in 5-6 years. I hope we trend it down. This is the years, percent using in the past month. Very common among our younger patients. Very common among our patients who are in their 20s and teens. And what? Regular. Good question. This is where sources obtain medications from. You'll notice that the vast majority of patients who obtain medications obtained it from a friend or a family member, and of those, one doctor was the prescriber. So it's very common to see one doctor give it to one patient, and then that one patient gives it, rarely sells it, but gives it to a friend or gets it stolen or something along that line. Urine drug screening, again, we talked about this. We used to do the dye test. We used to do that, and we might still do that. What I do is we'll try and do it at least 2 times a year on a quarterly basis. But what I'm really looking for is, what are my triggers? My triggers are lost prescription. Before they get, we don't refill lost prescriptions, but before they come in and pick up a new prescription, I'm going to do a urine drug screen. I'm going to do a urine drug screen to make sure that there's no drug in their system. And also I'll do it for people, I do it for every new patient across the board. And we explain to the patients why we do it, and we'll do it to our 80-year-old ladies, and they won't bat an eye because we're explaining to them why we do it. So again, it's a lot of just explaining to the patient. You know, self-treatment of poorly controlled pain is probably the #1 reason that people are out of their meds early. They do self-treat, and I'm not convinced that that's certainly not addiction. It borders on abuse, especially if it's a pattern that persists. Psychological issues, again, will cause problems, but the big one you're looking for is the abuse and the diversion issues. I had a guy come in, and I'll tell you the story, but he came in and he gave my girl, he was a 28-year-old guy, back injury. I think he was work comp. He comes in and he gives a cold urine. And the girls tell him, hey, your urine's cold. Oh, I'm so sorry. And he just begged for forgiveness and then proceeded to give his own urine. So we checked his urine. It was positive for marijuana, and that's what he was trying to hide. But we checked the urine he bought that was cold and had cocaine in it. So I don't think he got much good for his money. I'm looking for illicit drugs. I'm looking for non-prescribed drugs. Remember, you got to know your pharmacology. Hydrocodone is broken down to hydromorphone. Oxycodone is broken down to oxymorphone. So it's just the general stuff that you got to be aware of, the breakdown products. So the summary and protection, get the old medical records. I think that's very, very important from a standpoint of trying to determine what's failed, what's worked. talk with the pharmacist, routine follow-ups with the 4As, opioid treatment agreements, drug screens, record of lost, stolen, early requests. Make sure you keep a record of those requests. What we do is we have an electronic chart system. We're very blessed to have that. But we have a list of the meds, and it puts a little red box before lost meds, stolen meds, requests for early refills. And I always look at that and I say, if there's one or two in the last year, that's understandable. But if there's multiple, then that's a problem that hasn't been addressed and needs to. Common mistakes. Again, I think probably one of the most common mistakes is escalation of opioids, despite no evidence of improvement, not only in pain but also in ADLs. More importantly in ADLs, pain is so subjective, and pain will fluctuate by what they did the day before, the barometric pressure, the stress they're under. It's not pain scores that really tell you a whole bunch. It's how do they look? Are they finally putting on their makeup when they come in? Are they finally bouncing around the room? Are they finally bragging about how much weight loss they've had? Are they finally bragging about how much they're using the treadmill? How much they've been able to enjoy their kids and going out versus the person that you saw the first time maybe who came to you on high-dose opioids is just sitting in the chair in a daze, and you kind of got to halfway wake him up during the interview. That's not the way patients should go through life. That's not what we should do to our patients. There's no pain that's that severe that a patient with chronic benign pain should be put through that. Opioids used in pain syndromes known to be poorly responsive, that's an issue. Failure to document will get you in trouble. It'll get you in trouble because you're not practicing medicine right. I mean, it's documentation. When we have somebody come in with hypertension or with insulin-dependent diabetes, you'd be amazed at how some physicians document more their diabetes with A1Cs and with the appropriate blood work, but we don't document pain and we don't document function, and we got to do that. And lenient with abuse behaviors, we just can't be. Addressing obvious abuse, I wean them. I'll get them help. I will get them help. Now, obvious abuse is contact law enforcement. What do I do? Yes, I will. If I've signed somebody forging a prescription, if I find somebody who's going to 10 different doctors in the OBN, I will call the authorities, and we'll also call the other physicians on that list. Somebody who's going through their meds too soon, I tell them I can't go or something. I can't give you any more meds. I mean, but weaning sometimes you have to do, and you refer for appropriate help, you get them the appropriate help, and you treat withdrawal if indicated, but you don't have to give them a 30-day supply of opioids. They've just burned through the ones they had. They've just sold the ones they've had. You're basically giving them a loaded gun. In certain circumstances, consider referral, but this is the bottom one is what I always pay attention to, and under no circumstances, and this was from the white page, the DEA white pages, the Federal Register back in 2006, under no circumstances may a physician dispense with the knowledge the drug will be abused or diverted. And that's pretty heavy stuff if you think about it. You've got to protect yourself. Thank you very much.